All right, good morning, everybody. Wow, that was intense. I hope you're all doing well and ready for a fun week here at San Antonio. This is the Project Lead Advanced Topic Session, and we've been working with the Alamo Breast Cancer Foundation for more than 10 years to deliver this program every year to advocates that sort of sets the stage for the rest of the very intense week that you're going to have. And also, welcome to everybody who is joining us online. All right, so the first thing I want to do is just thank our sponsors. So we wouldn't be able to do this programming if it weren't for our sponsors. And as I mentioned, this year and for the last 10 plus years, we've been working with Alamo, who has its own set of sponsors that help them put on this week-long program and offer the scholarships and programming that they offer. And those are listed here. So again, the sponsors for ABCF, and then also the sponsors for NBCC Project Lead. And I just wanted to make sure that we recognize them because they allow us to bring about all of the programming, including the Project Lead Institute that we offer every year, and the webinars and these sessions for advocates. So I just wanted to thank our sponsors. Before we go actually, today's program is Sasha Stanton. She is a longtime NBCC faculty member, and I will introduce her here shortly. But this is the program that we're bringing to you today. She's going to be speaking about vaccines, past, present, and also looking to the future. And I ask when we get to this session, if you allow her to do her presentation and then hold your questions until we're done with that. We'll have plenty of time, I think, to sit down and take questions and have some further discussion on this topic. But before we begin, NBCC always starts every program that we have with a moment of silence to remember an advocate who lost their life to this terrible disease. And so today, I'd like to ask Marilyn Miner to come up to the stage and do the moment of silence for Sharon Folan.
Good morning. Sharon Folan was a passionate advocate. Her interest in breast cancer began with her family. Her mother was diagnosed with breast cancer at age 38 and died at age 43. 4 of her mother's sisters also died from breast cancer at young ages. Sharon was diagnosed with breast cancer for the first time at 35 and became active with the breast cancer community a few years later. She was diagnosed with a second breast cancer at age 64 and again in December 2022 with metastatic breast cancer. Sharon thrived in volunteering, supporting nonprofit organizations, and personal support. She served as an NBCC team leader and state coordinator for many years, attending advocate leadership summits and lobby days and advocating for NBCC's legislative and public policy priorities. She was also a Project Lead graduate. Sharon was involved as a peer navigator at Force, an advocate in science at Susan G. Komen, and a woman cancer advocate for Huntsman Cancer Institute, a part of the ACCR Scientist Survivor Program, as well as many others. She also worked with scientists as an advocate for many research proposals. Sharon was a teacher of 42 years and loved her students and colleagues. Sharon passed away from metastatic breast cancer on January 21st, 2023. Please join me in honoring the life of Sharon Folan. Thank you.
All right, thank you for that. So before we get started, and before I introduce our speaker, I would like to just share with you a couple of the upcoming events that we have. Hopefully we'll see some of you there. In 2024, we have our Advocate Leadership Summit, and this is really our premier event that we bring to advocates every year. Our leadership and new advocates who want to get involved in both research and public policy advocacy. And so that's going to be May 4th through the 6th in Washington, D.C. And there's a code here that you can, we have some flyers out front too that have this code that you can search for the event page for more information. And just so you can see, This is just a preview of the program that we're pulling together right now. And we will be putting on another Project Lead Advanced topic session during our summit, and that's going to be on the tumor microenvironment and its influence on metastasis. And we'll have Mikola Egblad, who's at Johns Hopkins, doing that. But the program will also include a number of different plenaries. We're obviously going into an election year, and so healthcare is going to be a big topic. So that's going to be something that will feature in a plenary and other topics as well. And we also bring many advocates education and skill building sessions that are meant to help you with your advocacy throughout the year. And then of course we top it all off with a lobby day, which is probably one of the most exciting parts of the summit. So I really encourage you, if you haven't been, to come. The other thing that we're doing is right now we're accepting applications for Project Lead. How many of you in here are Project Lead graduates? Probably most of you, right? Well, some of you aren't, because you're here with the Alamo Advocate program. And so I would encourage you, if you're not familiar with this program, we're accepting applications right now. We've been doing this since 1995. This is, NBCC has really pioneered advocate education, and it was in 1995 when we actually developed the Project Lead program. We've taken it across the globe as well in a number of years, and so it's a very well respected program, and advocates who come out of that are very highly revered. So we're accepting applications next year, July 28th through August 2nd. So please check it out. We have some flyers out on the table if you haven't had a chance to check those out. We also have some upcoming webinars that I just wanted to draw your attention to. Actually, next Tuesday, we have a Project Lead webinar on the topic I think is interesting to many advocates right now, progression-free survival, what it means and how patients value it. And we're going to be hearing from really two very well-known investigators, Elizabeth Eisenhower, who was very much involved in the development of the RESIST criteria, which is where progression-free survival came from, and then also Mike Brundage, who has done a lot of research into measuring how do patients feel about that metric. So that should be a really great session, and I highly recommend that you sign in for it. And you can find information about this on our website if you have not yet registered for it. We will also be doing a San Antonio highlights, so highlights from this session on January 26, 2024, and that's going to be presented by Sarah Hurwitz, who does such an excellent job doing that. So those are some of the upcoming events, and would like to encourage you all to check those out and join us if you can. So at this point, I'm going to introduce our speaker. All right, good. Her slides are already loaded. So as I mentioned, Dr. Stanton has degrees from the Albert Einstein College of Medicine in New York. She completed her residency in internal medicine at New York Hospital, Weill Cornell Medical College, and her hematology oncology fellowship at the University of the University of Washington and the Fred Hutchinson Cancer Research Center. She was an immunology postdoctoral fellowship. She did that fellowship with her mentor, Dr. Mary Desis, at the University of Washington Cancer Vaccine Institute. And she was promoted to assistant professor in 2017. Dr. Stanton then moved to Portland, Oregon in January 2020 and is a member of the Department of Medical Oncology at the Earl A. Childs Research Institute. Her research focuses on antigen discovery and vaccine design for breast, as well as head and neck squamous cell cancer prevention vaccines. But she's also interested in immune modification of the tumor microenvironment of breast cancer, and her clinical work is in the breast oncology group at the Providence Portland Cancer Center. And I will just add, she's also a long-time faculty member for the Project Lead Institute, and we're so fortunate to have her. So welcome, Sasha.
Good morning, and it's great to see so many Project Lead grads. As any of them will tell you, I get nervous and talk really fast. So, New Yorker. So please, I have my moderators in the audience that I've already picked out to tell me to slow And I welcome any questions afterwards. This is a broad trip through breast cancer vaccines, the different types of vaccines. Although now with COVID, we're all sort of becoming more experts than we ever wanted to be. But let's see where we can get with this. So really to start, we have to start with a tumor environment, because even in pre-cancer and definitely in cancer, it is not a monolithic singular thing. Your tumor cells are different. You may see in when you're looking at grants, well, they talk about heterogeneity of the tumor. That means that different tumor cells, different clones express different amounts of things, different amounts of proteins, different mutations. There are fibroblasts, so there are normal cells that are associated that can influence the tumor environment. There are immune cells, which of course the most important thing, I'm an immunologist. There are blood vessels, there are lymphatic drainage. All of it is affecting how the tumor responds to therapy and how the tumor responds to the immune system. And so you're going to hear me talk a lot about a type 1 and a type 2 immune environment. And frankly, what this means, if you think about your immune system really is focused on, sorry, I touched my lavalier and it makes a lot of noise. Your immune system really is focused on trying to eliminate things that it doesn't see as itself. So viruses, bacteria, fungi, things from the outside world. And so the type of immune response that you develop for that is a type 1 immune response. It's very inflammatory. It develops type 1 helper T cells. It activates cytotoxic CD8 T cells. It activates type 1 innate immune cells, neutrophils. Anyone who's had chemo will know that word. Dendritic cells, macrophages. And its goal is to stop blood growth, to kill whatever abnormal cell is there, and to induce immune surveillance. So if anyone's gotten that COVID booster, I just got mine, you will remember afterwards you feel like punk for a day, and that is your immune system remembering, oh yes, I've had this COVID vaccine before. I am going to increase all of my lymph nodes and get ready for an infection that then I can develop memory to and not when you actually see the COVID virus, get really sick from. Unfortunately, your tumor is you. It looks a lot like yourself. And so your body wants to heal that like a wound instead of eliminate that like it would a virus. And so it instead induces more of this type 2 immune response. Regulatory T cells that are saying, you know, you really don't want to eat yourself, calm down. Type 2 macrophages that, again, really change that immune environment. Immune checkpoints that basically tell T cells, okay, whoa, cool your horses, turn on, put the brakes on. And so this is proangiogenic. It induces tissue remodeling, and it suppresses and prevents the immune system from doing its job. And so really the goal of vaccines and all immunotherapy is to try to tip that balance into more of this inflammatory immune response. And we see this across tumors. This slide is growing hairs by now, it's so old, but this is looking at 60 papers, 120 papers, 60 different tumor types, including breast cancer, and really showing that a CD8, which is this cytotoxic T cell, type 1 memory T cell immune response has better prognosis across these breast cancer types, whereas the regulatory T cell anti-inflammation immune response has much more of a tumor poor prognostic immune response. And we see our immune system recognizing the tumor starting very early. My mentor, Nora Desis, used to say that she would go to conferences and people would, like this one, and people would get up and say, breast cancer is not an immunogenic tumor. And she'd be like, no. And we know that. When we look at the breast, and all we're seeing here, I don't think I have a pointer, but all we're seeing here is that the normal breast, CD45 just means it's looking at immune cells, it's looking at lymphocytes, and we really don't see a lot of immune cells in the tumor. When we go from normal breast to ductal carcinoma in situ, now you see a lot of these dark blue cells surrounding that DCIS, and those are all immune cells. The immune system is seeing the tumor. It's not necessarily infiltrating the tumor, unfortunately. And then when you go to invasive cancer, you actually get even more immune recognition of the tumor. So the immune system knows there's something going on. But again, the tumor and the immune environment and just starts telling the immune system, hold your horses, you can sit outside, but don't come in. Unfortunately, also, the immune response that develops is not quite the immune response we want. A lot of those immune cells, particularly as you get into DCIS and invasive cancer, are type 2. FOXP3 is another marker of type 2 immunity, and so suppressing your immune response to the tumor. Now, clinical, right? This is what we all want to get to. This is data in triple-negative breast cancer from Shireen Loy and Sylvia Adams, 2 different studies. Shireen Loy just looked at lymphocyte-predominant breast cancer. This means breast cancer that has more than 50% immune cells either surrounding it or in the tumor. And when you looked at these triple-negative patients that had those immune-high tumors, they did very well. They had a much better survival than patients that had no immune infiltrate in their tumor. And then Sylvia broke this down, and these are early-stage patients who've never received any therapy at the time of surgery prior to them getting adjuvant therapy. Sylvia further broke this down into quartiles. Every 10% increase in tumor-infiltrating lymphocytes improved the outcome of those patients. And both in disease-free survival, so these were patients who after their adjuvant therapy did not recur, and in how long they lived after receiving their adjuvant therapy. So this is triple negative. I can hear the people in the audience going, well, that's great. I have ER-positive breast cancer. What does that mean to me? So we know that the immune system plays a role across breast cancer subtypes, and we're getting a much better idea of this. Triple negative tends to have the most immune infiltrate and has the most lymphocyte-predominant breast cancer, also the most benefit from this. It tends to have more CD8 T cells. Remember, those are those cytotoxic killer T cells in the tumor. And the amount of FOXP3, those regulatory T cells, don't seem to matter as much in triple negative and in HER2-positive breast cancer, which similarly can show, we've now found shows both disease-free and overall survival with increasing lymphocyte predominance. But unfortunately, our hormone receptor-positive breast cancer, HER2-negative breast cancers, tend to have many more of these FOXP3 immune cells in them, and they predict for worse outcome. And a lot fewer of them are lymphocyte predominant, and that does not show the same benefit that is shown in our triple negative and our HER2 positive patients. So what can we do about that? And that's really where we can use therapies such as vaccines, but there are many other therapies to really change that immune environment that we start with and try to modulate it to increase the type 1 T cells and activity of those cytotoxic T cells, decrease those regulatory T cells and the immunosuppression. And these can include vaccines, cytokines, which are chemicals, immunomodulatory antibodies, which is a fancy way of saying immune checkpoint inhibitors, or OX40 agonists. There are many, many types of immunomodulatory antibodies, as well as some chemotherapies. And I always have to convince my patients, but please do not memorize this slide. I don't show this to my patients. They would run screaming. You're made of stronger stuff. But we know that a lot of the chemotherapies that we give do affect the immune system. Adriamycin increases CD8 T cells. That is doxorubicin. I've put the red arrows on the 4 chemos that we really give a lot to our breast cancer patients. And I chose cisplatin because they didn't have carboplatin here. But all this is saying is there are many ways that the immune system can be triggered, even by chemotherapy. And so I don't think we're doing this as much in breast cancer now, but in some other cancers, such as ovarian, we're actually giving vaccines along with chemotherapy and still having immune responses, even though we're giving chemotherapy. So, types of vaccines. And I'm going to try to touch on all of these. But really, the goal, there are many, many types of vaccines. There are many of these that are in clinical trials. And we don't yet know which ones are the winners. And these include dendritic cell vaccines. So taking your dendritic cells, which I always think look like a big octopus. They just show lots and lots and lots of, they can give signals to lots and lots and lots of T cells. They're called antigen-presenting cells. There are peptide vaccines, which are small portions of a protein. There are whole tumor vaccines, so you either use killed tumor cells or parts of tumors. There are protein vaccines where you use the whole protein. Plasmid vaccines, and I really want you to here to think about nucleic acid vaccines, because RNA vaccines are really making a inroad, and I think we're going to start seeing stuff in breast cancer too. It's big right now in melanoma. It always starts in melanoma. And then carbohydrate vaccines. This is like the MUC1 vaccine. I'm going to talk a little bit less about this. And so now you have to think about the type of vaccine, all of those different ones I mentioned, the type of adjuvant. All this means is what is going to bring that immune system to the vaccine and make it work. The type of immune response you want. As we understand more about the immune response, some people want to activate those killer T cells. Some people want to activate helper T cells. Some people want to activate B cells. So that will depend on, when you're reading a grant, on what kind of vaccine you're looking at. And specificity. You really want it to target that tumor, wherever stage that tumor is in, and not target normal cells. So, just a little bit of background. Project lead is going to know this. I unfortunately do not have my partner and better half, Sylvia, with me here, but we've got three things that I'm going to talk a lot about. Antigens. What an antigen is that little piece of protein that triggers that immune response. So that is from the tumor. In the COVID vaccine, that antigen is the spike protein, right? You all have heard that. So that is this little piece of pathogen that you present in a very specific way on an MHC molecule to the T cell that lets that T cell be a very specific T cell. Receptors are how the cells communicate. One of the best examples for a therapeutic receptor is HER2, ER, PR, right? Those are all receptors that are able to communicate and tell cells to grow. Another receptor is PD-1, PD-L1 that tells the T cell, whoa, slow down, calm down, don't be active. So there are many, many types of receptors that really direct the immune response. And then there are cytokines. Literally, it's just cell chemicals. Cytokines. And these are small proteins that chemicals that again, tell the T cell how to respond. So you need all three of these to get an appropriate immune response. And so basically what happens is you get a stimulus, a tumor, an infection. You have an antigen-presenting cell that takes up the broken up pieces of that tumor, presents it in a way that a T cell can see, and shows it to the T cell with receptors and with cytokines that then direct what that T cell will develop into. Hopefully for us, we develop a type 1 T cell or a CD8 T cell that's active and ready to go. They go into your immune system, go back to the tumor, and destroy the tumor. That is how we plan this to go. So my research interest is immunoprevention. And so I'm going to do a little bit on immunoprevention because Michelle told me I could. She released the Kraken, what can I say? So immunoprevention, really the reason that we want to move this forward is that we have seen in the past when we have vaccinated women who have very metastatic disease with just a vaccine alone, we may not get the immune response that we need. And there are many reasons for this, right? You can think of some. You've had invasive cancer for a while. You've had cytotoxic therapies. Your immune system is immunosuppressed. The cancer itself actually suppresses a systemic immune system. We see that natural killer T cells are less effective in patients that have that have more advanced disease. Also, the tumor itself has grown and mutated such that it has developed ways to evade the immune system. And this can be including fibrocystic sheaths, so basically surrounding the tumor and preventing it from the immune system from even seeing it, or increased immune checkpoint inhibitors that, again, tell the immune system to turn off. As you get earlier into even local cancers, again, you have a more established tumor that is invasive and that is very able to have mutated enough that it's survived being attacked by your immune system. Your immune system does see your tumor and instead is continuing to survive. And as you get into precancerous lesions, these lesions are slower growing, they're less well established, and so they're a lot easier for the immune system to see and to have the time to see and eliminate. And the ideal, where we all want to get to, is patients at high risk for cancer. I had someone on the flight yesterday ask me, well, that would be vaccinating all women. And I said, hey, if I had something that was safe and would prevent breast cancer, do it. Eliminate my job. I'm fine with that. So I'm not anywhere near that. We're still working on it. But the goal would be to be able to vaccinate someone and prevent them, just like you would with the measles vaccine or the COVID vaccine, to prevent them from ever having an abnormal cell that their body couldn't eliminate. And I'll talk about some trials where we're trying to get there. So that this is not just pie in the sky, there are actually FDA-approved prevention vaccines, but they are to viral cancer-inducing viruses. So this includes the HPV vaccine. I'm saying prevent cervical cancer because that's what we have the best data for, but we are starting to get data that it also prevents head and neck cancer and anal cancer, all caused by the HPV vaccine. Most effective when you give it to patients who've never seen HPV before, which is why we give it to young patients. And the hepatitis B vaccine and hepatocellular cancer. So it's not as big of a deal in the United States. We don't have as much chronic hep B. But chronic hep B infection was a huge issue in other parts of the country, other countries. And in Taiwan, when we got the hepatitis B vaccine, they started a universal vaccination at birth. And they were having huge rates of up to 400 patients a year with pediatric hepatocellular cancer. And that dropped down to 6 in the entire country in the first 3 years of this vaccine approach. So it's incredibly important in the world, but the hepatitis B vaccine, really, the big thing it prevents is hepatocellular carcinoma and chronic hep B infection, which leads to hepatocellular carcinoma. Similar with HPV. Again, there are some studies showing that it can eliminate cervical neoplasias, but really the strongest role of it is in doing it prior to anyone being exposed to the virus. So just to show, we have good data for very large viral induced cancers. But what about cancers that are not virally induced, such as breast cancer? And so this is really where we get to primary prevention. And I can already hear Shizuko say, who's the head of the NCI Cancer Prevent Group, that primary prevention really is preventing people who've never had cancer. I also think of it in preventing people who have not had invasive cancer but have had precancers, like DCIS or LCIS or the atypical hyperplasias, which make them have a higher risk of cancer, and really just try to prevent them from having that ever come back or ever going on to invasive cancer. And so there's really 3 different types of pools of people that are having this developed. People who have genetic mutations, BRCA, FAP, HNPCC, which is Lynch. People who have a very strong family history, but maybe not a genetic mutation. And then people who've had pre-invasive cancers like DCIS. So just to remind you, I'm going to be talking a little bit about neoantigens. Just to remind you, when you look across the spectrum of neoantigens, neoantigens are mutations in a tumor that can be directed to the immune system so that you get, remember you wanted to get that tumor-specific immune response. Well, melanoma, lung cancer, both of these are caused by either sun or smoking, have a high mutation burden. Unfortunately, breast cancer, we tend to have a much lower mutation burden. Some of our BRCA mutation carriers are really what pull us up on this, quite honestly. And so we don't have all of these conserved neoantigens that some of these higher mutation patients do. But what a neoantigen is so you have a chromosome and you have a small change in your DNA. So when that's transcribed into mRNA, oh, sorry, it went so fast, and then a protein. Let me see if I can go back. There we go. It's correct. And then a protein, you get a little abnormality. There is a little red line on that protein that went whizzing by that is mutated, that isn't normal. The rest of your cells do not have. And that, again, remember, we talked about a receptor and that T cell receptor, MHC, with that antigen, that little piece of the pathogen put in it. If that mutation is there, that T cell is specific to that mutation. We're going to talk about this several times, both in prevention and in invasive, in treating established cancer. But that is what a neoantigen is. And so I know this is in Lynch syndrome. This is actually a colon cancer. Although Lynch syndrome patients also get breast cancer. I've had a few of those. But this is work done by Dr. Villar Sanchez and MD Anderson. He's a GI doctor. So he's thinking about colon cancer. But what he did was he looked at 209 neoantigens that were conserved in these Lynch syndrome patients. So these patients have a lot of mutations. They have 6 genes that are mutated in their body that they inherit, and they have very, very high risk of developing cancers because of all of these mutations. And so he's found 209 of these that are conserved across tumors in Lynch syndrome patients. And he originally did a phase 1 study where he went into Lynch syndrome cancer patients and vaccinated them with this. And this is a viral vaccine. So he gives, which is similar to what's being given for the Artemis vaccine for the NBCC folk. So he gives adenovirus vaccine for the original vaccine, and then for boosters he gives a modified vaccinia virus. And he first went into cancer patients, showed that it was safe, showed that they got an immune response, and now he's going into 45 high-risk Lynch syndrome patients who have no cancer. And the hope is to follow, do they prevent developing tumors and polyps? So another way to think about vaccines is vaccinating against tumor-associated proteins. These are for those cancers like breast cancer that don't have all of these conserved mutations between patients. And so just to show you on the right, yes, on the right, I'm sorry, I'm looking at it face forward. On the right, when you're looking at HER2 expression, when you look at HER2 1+, 2+, and 3+ expression, HER2 3+ has a lot more HER2-directed T cells that develop in these patients, even prior to therapy. So just having this overexpressed protein develops more of a T cell immune response against it. And why this happens is that normally, in a normal expression on a cell, you're going to have mostly this dominant epitope, this piece of antigen that the T cells see all the time and say, yeah, I know, that's me, I'm going to ignore it. Now when it's overexpressed, you have a lot more of these subdominant abnormal antigens on the antigen presenting cells that now the T cells can get activated to parts of the protein they wouldn't normally see in normal expression. And so this data is from Dr. van der Heide and Dr. Domchek, and Dr. Domchek was wonderful and lent me these slides. And so what they started with was human telomerase is overexpressed in many cancers, including a lot of breast cancers. And they did an initial phase 1 study across cancer types. This is what's called a basket study, where they vaccinated patients with a DNA, a plasmid vaccine containing the protein TERT, as well as an IL-12, which is a cytokine that activates dendritic cells, so these presenting cells that will present the antigen, in patients with high-risk solid tumors after surgery and potentially neoadjuvant chemotherapy. And they found that it was safe, so that everybody developed an immune response to this TERT vaccine. And in pancreatic cancer patients, which they had the most of, they actually found that they did better. They had lower recurrences than you would expect in a pancreatic cancer population. So now Dr. Domchek is going into BRCA carriers, BRCA1 and 2 carriers, and they started cohort A in BRCA patients with cancers. So this could be breast cancer. They have a large pancreatic population. And they did 16 arms. This now has 3 antigens, not just HTERT. They added WT1 and PSMA. And they're testing it with and without this IL-12 plasmid. And now they're going into healthy subjects with a BRCA mutation, again, to try to prevent recurrence. And this is in 28 patients, 14 subjects per arm. And they've already enrolled the first 9 patients. And that's being run through University of Pennsylvania. So why do we want to go into patients with premalignant lesions? Low disease burden, they have slower disease growth, they allow the vaccine therapy takes longer than cytotoxic and chemotherapy. Their immune system is relatively intact, and hopefully we can develop memory so that they not develop invasive breast cancer down the road. So we know in DCIS that increased FOXP3, remember that's that regulatory T cell expression, predicts shorter relapse-free survival and overall survival. And in genetic studies of DCIS, they've found that a type 1 gene signature actually predicts for better relapse-free survival as well. So the initial vaccines in DCIS were dendritic cell vaccines for HER2. Again, what a dendritic cell is, these are antigen-presenting cells. They present those little pieces of protein to T cells to develop an immune response. So what you do with a dendritic cell vaccine is you do a leukapheresis, which is basically just a big, sucks all the blood out of you, spins it down, and takes off the dendritic cell populations. You then show them the antigen you're interested in, you grow it up, and then you give it back to the patient. And so this is a HER2 DCIS vaccine. This was given in women who had HER2 positive DCIS, and I can hear all of you who had DCIS going, wait a minute, I don't know if I had HER2. They had to do special testing because we don't test for this clinically currently. And they did this in 13 patients. And in 13 patients, they found that 16.4% had no cancer, no DCIS at the time of surgery. So this was prior to surgery. So they vaccinated for a month prior to surgery and then took the patients to surgery. So 16% had no DCIS at the time of surgery. However, the remaining patients had lost DCIS expression but had remaining DCIS. So remember I talked about how the tumor was heterogeneous? The vaccine targeted all of the parts that were overexpressing DCIS. It's overexpressing HER2, but the parts that weren't continued to remain. And so they've actually now done a second phase 2 trial with this in 27 patients, similar, about an 18.5% that had no DCIS at surgery, but the remaining had residual DCIS. So the DCIS group said, well, maybe one of the problems with this is you're only vaccinating against one antigen. What if we do multiple antigens? This, I will warn you, is mice. This is not in human. I'll get to the human data a little down the road. But we have mice that overexpress DCIS and have genetically similar tumors to our luminal B tumors. These are TGM-MTB new mice. But when we now vaccinated with 3 antigens, which were 3 favorite antigens because we knew they were overexpressed in invasive breast cancer, HER2, IGF-BP2, and IGF-1R, we found that A is showing that these mice were 98% of them developed cancer. Now 65% did not with the 3 antigens. And C is showing if you do each of the individual antigens, you actually have less, they're not as effective as doing all of it together. And you get increased CD8 T cells with the vaccine. But my question was, why are we just picking our 3 favorite invasive antigens? Why don't we look at antigens that are conserved in DCIS and invasive cancer? And so just to let you know how slow developing clinical product is, I got the my first K award for this in 2014. So I have been working on this for a very long time. This was my postdoc research. But basically, I looked at genes that were overexpressed in DCIS and invasive cancer and picked the genes that were most overexpressed in both across the GeoArray data sets. So these are national curated data sets. I found that not only were they overexpressed by RNA, which is what most of these data sets did, but also by protein. And then I went into human breast cancer cell lines. I actually also had a DCIS cell line, but it grew too slow. And I knocked down expression of each of these genes and tried to see which of these genes, I had 68 to start with, which of these genes actually killed breast cancer more effectively than a normal breast cell line, human breast cell line. And I had 13, I know, lucky 13, genes that actually killed breast cancer more effectively. And those are the genes that are here. So interestingly then, I wanted to see, are these genes immunogenic in women? I had a lot of help from Duke, who had a huge sample of DCIS samples of women who had gone in for an abnormal mammogram and then had their blood drawn. They sent me those. I had breast cancer from our CVI breast group, blood samples, and then I had blood samples from patients who, as far as we know, have no breast abnormalities. They had donated blood at the Puget Sound Blood Center. So I then said, can I see antibodies in women who have DCIS or invasive cancer that I can't see in patients that don't have invasive cancer? And I can. And if I look at, this is actually looking at 9 of the antibodies. My technician is busily finishing up the last 4 ELISAs as we speak. But I am able to predict with a very high AUC, so a very high area under the curve. What you're seeing there is a ROC curve, basically saying that if you look at all of these antigens, you can predict up to 99% of DCIS patients in my discovery sample. So whenever somebody shows you data like this, what you have to say is, great, you showed it in one data set. Can you show it in an independent data set? And we actually did. So we got a completely separate independent data set from the Fred Hutch and did all of these ELISAs in validation in an independent data set. Now you're going to notice these AUCs are lower. We only have done 4 of the 12 so far in our validation set. So our AUCs are not as impressive, but I think as we finish up that we'll see a lot more of these autoantibodies. So we know the immune system is seeing these antigens. We know it's developing an immune response, but unfortunately it's developing an immune response that's inducing antibodies, which is a B cell response, which typically is a suppressive immune response. But it's exciting because it means that your body already sees these antigens. Now can we train it to be more of a type 1 anti-tumor immune response? And also, excitingly, we could identify each of the subtypes of breast cancer, which I wasn't able to show. The DCIS lab, we tend to do a lot of HER2, so we had a lot of HER2 breast cancer. So now what we're doing is I want to identify the parts of the protein that specifically induce a type 1 immune response, an interferon gamma immune response. So I'm selecting epitopes. These are looking at 20 breast cancer patients and showing that when we show them these little pieces of protein, we're selecting the targets that produce a specifically type 1 immune response. These are helper T cells. And why we want to do that is because helper T cells both change the tumor immune environment as well as can induce CD8 T cells. So we'll get those cytotoxic T cells that can eliminate the tumor. We can also make the tumor more hospitable for those working. So I'm a CD4 girly, but you know, to each their own. And then we always have to go back to the mice. I only have 1 so far, but we have 2 transgenic mouse models, and we have shown that One of the vaccine targets, KRT8, human vaccine, human epitopes, and can inhibit tumor growth in both the TGM-MTV-NU, which is like luminal B, and the C3T, which is a triple negative mouse model. And all of these targets are overexpressed in both of our mouse models. So I know there are a lot of people that are like, well, great, you're talking about prevention. I have breast cancer, so it doesn't apply to me. Well, we also have secondary prevention, and this really is much more thinking about eliminating residual disease. So people who have had all of their therapy and we want to eliminate either they have metastatic cancer, but they have very low disease burden, and we want to make sure that we keep anything down from what they have, or they've had stage 2 or 1 or 2 or 3 breast cancer, they've finished all of their active therapy, and now we want to eliminate anything that might be left. You may see these trials. There's a lot out there that people don't get a PCR with neoadjuvant chemotherapy, and then there's a vaccine after to try to suppress anything that might be remaining because they didn't get a complete response. So that's a lot of the trials I see right now in this space. And really what this is dormancy. What we worry about here is dormancy. That there's a period of time between diagnosis of cancer and recurrence. It can be months, it can be years, it can be decades. And the question always is, and any of you who've recurred have heard this question, well, is this a new cancer or is this the old cancer popping up again? And the answer is, for a lot of it, we really don't know. But when we've done genetic studies and checked the metastasis to the primary tumor, we can often see there are a lot of similarities, that they probably came from the same place. And this can be cellular dormancy. You've got one little tumor cell sitting there, it's not growing very quickly, it's either in mitotic arrest or there's death and proliferation are kind of balanced. Angiogenic dormancy, one little tumor cell doesn't have enough blood supply to do what it needs to do, or immune-mediated dormancy. And immune-mediated dormancy is that your immune system did see that tumor, and now it's a single tumor cell sitting in your bone. And so it's really able to inhibit all of that, inhibit that tumor growth with the immune system. And then something happens. Either the tumor mutates such that it's able to evade that inhibition, or you get sick, you get older, your immune system goes down for some reason, and now that tumor is able to come up where it hadn't come up before. And that's typically when you lose immune evasion, that you can have overt metastases. Another consideration for this are breast cancer stem cells. So there are also, as I talked about heterogeneity, there are tumors, and your tumor cells, but there are also stem cells in that tumor. So these are more pleiotropic. They can change to different things and are believed to be important for plasticity, for allowing for metastasis in different parts of the body. And so Dr. Jesus at the University of Washington looked at what were these breast cancer stem cell genes, and then found 5 of them that she designed a 5-antigen vaccine for. Also mice. You have to do mice before you do humans, or some pre-animal. But this is looking at our triple negative mouse, and that this 5-antigen vaccine given 3 times could inhibit breast cancer stem cells in that mouse, as well as inhibit tumor growth. And we did take this 5-antigen vaccine into a clinical trial. This was in stage 3 and 4 breast cancer patients who had no evidence of disease. So these were metastatic patients, but they either just had disease in the bone or had no seen disease. So you were starting at a low enough disease burden that a vaccine could possibly control it. And you got 3 vaccines 1 month apart, and then you got a booster. Really what this is looking for, this is a phase 1, 3-dose trial, was looking for safety. So we found that the middle dose was safe, and really the vaccine overall was very well tolerated. This is now actually in a phase 2 trial in stage 1B through 3 triple negative breast cancer patients who did not get PCR with neoadjuvant therapy. So just trying again to eliminate that potential minimal disease that might be remaining because they didn't get the response we wanted. Similarly, I talked about that 3 antigen vaccine. So we did take that into phase 2 and 3 patients. And again, very well tolerated, 3 vaccines, 1 month apart, immunogenic, and we found that the second dose was the most immunogenic. We now actually, the CVI, I left, it seems like not very long ago. The CVI now has a trial in HER2-positive breast cancer patients who did not get PCR, and they compare the dendritic cell vaccine that I talked about earlier to this 3 antigen vaccine. And interestingly, this isn't actually an ovarian model, but we found that this 3 antigen vaccine also decreased metastases when mice were vaccinated. And this is a very aggressive ovarian model. So this is a vaccine. This was a phase 1 trial. It was a CD8 HER2 vaccine with 3 antigens. I know, I see someone smiling in the front row because they were part of this trial. So this was in 22 patients who had HER2 metastatic disease and were vaccinated after they had completed their first dose of chemotherapy, and then were on Herceptin. And the exciting thing about this was that we saw when we vaccinated with these 3 HER2 antigens, we saw that these women developed immune responses to these antigens. They also developed immune responses to other antigens in the HER2 molecule. That's called interepitope spreading. And they developed intermolecular epitope spreading. So they had immune responses to other proteins like P53 that they hadn't seen in the original vaccine. So that bringing that immune system to the tumor with the T cells for the HER2 were educating other T cells to come to that immune system. Now, what was really exciting about this vaccine is that 10 years after the trial, I looked at the data and found that 10 of the initial 22 patients were still alive. And I reached out to those women, and some of them were like, no, I'm doing fine, please leave me alone. But 4 stalwart souls were able to come back and get another vaccine. And so we boosted them again. We did see, and I presented this at SITC last year, we did see an immune response to that booster vaccine in patients that are doing really well. Now, does that say a lot about where we've come with HER2-positive metastatic breast cancer therapy? Possibly. But also it's very exciting that so many of our patients are still living. So that was a win. This is a more recent vaccine. Now we're going into plasmid. This is a DNA vaccine just containing the intracellular part of the HER2 vaccine. Again, 3 doses, 66 patients were enrolled, and Arm 2 was the most effective. But interestingly, Arm 2 being the most effective actually had the best survival. So being vaccinated was associated with a better survival. And this is now in a trial in triple negative HER2 low. You're going to hear a lot about HER2 low in this conference, I am guessing, that did not have a PCR after neoadjuvant chemotherapy. So this is through Aston. So these things really are getting moved into trials. They take a very long time, though. But anytime that we talk about a HER2 vaccine, we have to talk about the E75 vaccine. E75 vaccine is also a CD8 vaccine. It's a peptide vaccine using GM-CSF, same thing you use, Neulasta, that you guys use in chemo, as your adjuvant. And so this is to get CD8 T cells, HER2-specific CD8 T cells. And the phase 1 and 2 trials of this were very positive. Patients, it was immunogenic in very advanced disease. Patients had improved disease-free survival as compared to patients that didn't get the vaccine. This is a peptide vaccine, so it has to be HLA matched. So HLA is your white blood cell type, just like your red blood cells have type, your white blood cells have type. And that can, unlike the plasmid vaccines, that can very much determine who can get the vaccine and who can't, and can genetically change who's eligible for the vaccine. But the phase 1 and 2 trials were safe and did develop immune response. However, unfortunately, when they got to the phase 3 trial, this was in stage stage 1 through 3 patients with HER2 low, so HER2 1 plus or 2 plus, node positive disease. As you can see with the progression-free survival, there was just really no benefit. So we really are figuring out, I've talked to you about a bunch of different ways that we can figure out how to make vaccines that are more effective, using more antigens, using new adjuvants, using different methods, including RNA, which is quite frankly very exciting. They have been doing now studies in melanoma, looking at using the mRNA vaccine, similar to what was done in COVID. Actually, the COVID mRNA vaccine was developed from a melanoma trial using neoantigens from 2017. So just putting it out there, cancer, we paved the way. But other types of vaccines, I promised you I'd talk about cell-based vaccines. How am I doing on speed? Everyone okay? Have I lost anyone yet? All right, we're in the home stretch. Cell-based vaccines. The proteasome is a degrader that degrades, basically, I'm from Portland, it's the recycling center of the cell. I'm kidding. I'm actually not kidding. It is the recycling center of the cell. But if you inhibit the proteasome, you basically can collect that recycling center and get all of those abnormally expressed, overexpressed tumor proteins. And then it's in a cell-free method so that you don't have to be giving people tumor cells, and you can use it as a vaccine. And this is called the dribble vaccine. It was developed by Bernie Fox, so all of these slides are by permission for him. David Page is one of my breast colleagues. He will be here this week. Basically, he went into a triple negative population where he gave this vaccine along with, remember I talked about the antibodies? Well, this is actually an activation antibody. OX40 is an activator. So OX40 antibody will activate your T cell, and anti-PD-L1 is going to inhibit any breaks on the T cells. So basically, he's vaccinating as well as giving an activation, 2 activation targets, and was able to get immune responses to up to 1,000 different targets using this sort of cell-free recycling vaccine model. This is being moved forward in head and neck. They didn't do as much with breast cancer because we had a lot less mutations than head and neck cancer did. But Bernie's not going to be free of me. I'm going to continue bothering him. So this is a bit of a stretch, but I'm going to call this a vaccine. This is kind of exciting for Project LEAD people because this is one of you. And this was done by Stephanie Goff, who is at the NCI, and as well as Zacharides is who the first author is on this paper. I do want to put out here, this is one patient. They've tried this on other breast cancer patients, and it has not been as successful. What they did was they took a tumor sample from a patient with metastatic disease. They extracted the DNA. Remember I told you I'd get back to neoantigens. And they looked for mutations in that tumor. And then they took that patient's antigen-presenting cells, and they showed all of those neoantigens to them. And at the same time, they took T cells from that tumor, and they put those antigen-presenting cells with all of these mutations along with those T cells, and they selected for the T cells that grew up and proliferated. They took those T cells and they gave them back to the patient with immune checkpoint inhibitors. And this was the response. This was a patient with widely metastatic disease who had been told, this is it, this is all we can do. And so she went to the NCI for this trial. And Stephanie loves having things zoom in, so she had the 42-month one zoom in, but I find them very distracting. So I took it out, but she at 14 months had a complete response, and at 42 months had a complete response. Now, as Stephanie will always tell you, I'm now speaking through her, this was one patient. They've done this in 18 others, and they've had partial responses, but they have not had responses such as this. So it's not sure why one person would have a complete response and one person would not. But it was using those mutations and looking for T cells specific to those mutations to get this response. Similarly, sort of flipping that on its head, we did a similar trial in progressive patients with metastatic HER2-positive breast cancer where we vaccinated them with the HER2 ICD, that intracellular domain vaccine, prior to collecting their T cells. And so we're trying to activate more HER2-positive T cells. We then grew them up, gave them back after we'd given 1 dose of cyclophosphamide to kind of brings down some regulatory T cells. And this patient, then we did a PET scan 48 hours after we gave the T cells. And this patient who had lit up all over 48 hours after the infused T cells, including in a new spot in her head we didn't even know she had before. And then 30 days later, you'll see it's all gone. There's no more PET avidity. And so these T cells got to the tumor. They infiltrated the tumor. We did not get a complete response. She actually went off all therapy for 18 months, metastatic progressive HER2-positive breast cancer, but unfortunately then did end up progressing and succumbing to her disease. So we did not get complete responses. We got some partial responses and stable disease on this trial. There are other combos trying to add adoptive T cell therapy and vaccine, or neoadjuvant therapy and vaccine. This is looking at a viral vector again with pembrolizumab, radiation, or letrozole in HR-positive, HER2-negative patients as neoadjuvant therapy. There are basket trials looking at neoantigens and pembrolizumab in solid tumors, and there are many, 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 many more ways to combine in advanced disease vaccines and other therapies. So just having you have a look out for that. And then you can't go anywhere without being lifted up on the shoulders of giants. A lot of this was education from Nora Desis. She took a molecular genetics PhD and taught her immunology, which is, if I can do it, any of you can. And all of the people who helped me at the University of Washington Cancer Vaccine Institute. I'm still very involved with them. Nora wanted me to call my lab CVI South, and I told her I needed to have a little bit more distance than that. As well as the Earl Childs, a wonderful group of clinicians and physician scientists and scientists who focus on immunology day in and day out and are incredible resources. Jeffrey Marks at Duke, who gave me all of those DCIS samples, Charles Drescher at the Hutch, who did the same, and Susan Domchek, who I emailed her and said, "You gave such fabulous slides, can I borrow them?" And she went, "Yeah, sure," and just sent them to me. So, and then all of you for listening for so long to me blathering on. So thank you all so much.
But I have written down a number of things to discuss with you while we wait for questions. One of the things you didn't talk about, what are we learning from breast cancer in dogs? We were talking about mice, and you have to do all your studies in mice to start, but we don't really learn a whole lot, I think, from mice.
Well, so interestingly, dogs develop breast cancer spontaneously.
And we know that there are vaccines, right? So
yeah. No, absolutely. This is fascinating. And you have to be able to be in an area that does dog research. There's one at Purdue that does dog research, and LA, right? Is he in LA? Stephen
I'm not sure where he's located.
I know, I'm trying to remember where he is. But yes, dogs absolutely are, sorry, if you don't like mice, dogs are probably right out too. but dogs are absolutely develop, and they spontaneously develop breast cancer. And now you've horrified me, I have a new puppy.
Are we learning anything about the approaches that they're utilizing in a species that actually develops breast cancer?
Absolutely, because we're able to see all of our mice. A lot of our transgenic mice are virally based, right? And so they're not necessarily, we don't all have large T antigen inducing our breast cancer. And dogs are much more what we would be. They develop it with aging. They also age better. And so we're able to get antigens from dogs, and we're also able to really understand the immune system with dogs. The dog immune system is much more along the lines of us. But yes, no, absolutely, and it's a fantastic, and I think it's in the Artemis, right?
He's
Stephen?
actually participated in Artemis in prior
Okay.
years, but
He's
his
fallen
work
off with his work.
hasn't influenced the Artemis breast
Okay.
cancer prevention vaccine that much, and it's certainly not in recent years.
Okay, but absolutely,
So
no, absolutely, absolutely.
So we talked a lot about the different platforms that are out there, and I'm just wondering if, what vaccines in breast cancer have been going on for a long, long time,
Yeah.
and we haven't made as much progress as we would like to. So what are which platforms are really looking to be the most robust?
The exciting thing about the viral platforms is that you don't have to give anything else. That induces the immune response. That is the adjuvant, right? It's a virus that your body will say, this is abnormal, I'm going to develop an immune response to it. And those have been very exciting. I think that the DNA and RNA are very exciting, the nucleotide vaccines, because you can include a lot of different epitopes so that you're not doing just one, you're doing many different targets. And the RNA has been very good at developing that immune response, which sometimes we worry about with the plasmids.
Right.
Sorry.
I want to back up, because I'm not sure how many people are wondering about this themselves, but, and I see we have a line there. So we'll get to that in 1 second. Can you just describe the purpose of an adjuvant in vaccines? I don't know if anybody else has that question, and you talked about the fact that when you're using a viral-based platform like MVA, that's part of the Artemis vaccine. One component of the Artemis vaccine is viral-based. You don't need an adjuvant. So what is the adjuvant?
So what an adjuvant is it's just typically a chemical that brings the immune system to that area, right? So you, and really tells your immune system that you want to develop a type 1, an inflammatory immune response to this. So adjuvants you may see, poly-ICLC, which is a chemical that basically induces inflammation. GM-CSF, that is Neulasta. That is a cytokine. It's a chemical that brings dendritic cells to the area. So you just put DNA into somebody's arm. It's just going to sit there, but the immune system isn't really going to get to it. Now you add a cytokine like GM-CSF. Now you bring in those dendritic cells. And they pick up the antigen, and then they can activate and get it to where they need it to go. So that's really what the adjuvant is. In the Dr. Domchek's vaccine, it's IL-12, which is similar. It's a cytokine for dendritic cells.
Okay, so we'll go to the mic.
I just wanted to invite everybody to a poster tomorrow. It's PO2-17-12. I'm a consumer advocate on the triple-negative vaccine that's being tested at the Cleveland Clinic.
Oh, fabulous.
And our target is a protein called alpha-lactalbumin, which is expressed in high amounts in certain triple-negative breast cancer patients. And so what we're doing is we're giving patients that are just completed treatment within 3 years and giving it to prevent recurrence. And we have a really good immune response.
Fabulous. No, lactalbumin, I didn't, mammoglobin, there are so many targets.
Well, we're about to start the primary prevention phase.
Fabulous.
Which is
wonderful.
We're actually inoculating BRCA1, BRCA2 that are prophylactically getting mastectomies and making sure that it doesn't harm healthy tissue, as well as, that 5%, when you have a mastectomy, there's still 5% breast tissue. So we're going to follow them as well to see if they are protected against, cancer in the future. But we're still recruiting. If anyone knows someone with triple-negative breast cancer, high grade, that is within 3 years of completing treatment, we've inoculated 18 women. I think I said that. And if you look at the poster tomorrow, we've had a very good immune response.
All right. Yeah. Thank you. That's great.
Yeah, the poster number is P02-17-12, and the two investigators are Justin Johnson and Dr. Thomas Budd. And this vaccine took 20 years to develop, It was developed by Vincent Tui, unfortunately, who we lost this year in January, right as we were getting the results from the vaccine. But I'm located in Florida, but the vaccine trial is in Cleveland.
It's Cleveland
Cleveland Clinic. I didn't know when I was diagnosed. Didn't know anything about this, but I've been supporting them for about 14 years. So, but now we're in trial, and right now we're looking at phase 2.
All right. Well, thank you so much. If you get a chance, please go to that poster. We've been following that vaccine as well.
Hi, Michelle.
Hi, Patty.
Hi. I'm Patty Spears. I'm a patient advocate, and I'm a strong supporter of vaccines. I have a microbial background. I actually did the 2000 DCIS trial.
Fabulous! Yay!
I was in the middle dose, which is really good to me.
Which is good.
Yeah, really good.
So there are more than one patient here who has.
Yeah, Terry's the other one, right? Yeah. So me and Terry meeting Nora after a talk. So I'm such a strong proponent. This was a really nice overview, and I work closely with Kim Lyerly's group and Zach Hartman and stuff. So,
And they have a HER3 vaccine, right?
That they work on a lot of
I
different
know.
things.
Kim Lyerly's.
I didn't qualify for theirs because they required HLA-2, so I traveled to Seattle instead.
Yeah.
But I think that as we're looking at this, I think we actually have to look at context as well. I'm really surprised you brought up the Zernike study. That kind of aches my bones. I don't like that. I think when you look at prevention, you're not going to do a dendritic cell vaccine. Period.
Yeah.
End of story. For DCIS, you should not be doing a dendritic cell vaccine.
Oh, I don't think so
End
either.
of story. Yeah, I think
But it's a vaccine that's been brought to clinical trial in DCIS, which is why I brought it up.
See, I don't like that. So I think that as patient advocates, we need to think about the patient side of things.
Yeah.
I think doing that makes people with DCIS feel like they have something terrible.
Yeah.
And they need this treatment. They don't. I think that as we go into prevention, it needs to match the patient, just to keep that in mind as patient.
Well, it was really interesting. We were talking about this too, about adding an immune checkpoint inhibitor to a vaccine. And my answer is, I don't want to give a DCIS patient an immune checkpoint inhibitor, and the toxicity is related to, you really have to match your toxicities with your patient population.
Right.
So that's why my vaccine, I want to be
Just a shot in the arm.
a shot in the arm. It's a universal. I pick. This is getting way into the weeds, but I pick HLA-D, a universal type HLA class, so I don't have to HLA type anyone. I can do. It's for anyone. It's off the shelf because again, I don't want my DNA vaccine to just be. I don't want my DCIS vaccine to just be for HLA-A2 patients, and I don't want to have an invasive injection into a lymph node. So it's true. It's a tough vaccine, but that is the vaccine that's gotten into clinical trials.
And I tried to stop it. Yes. But I think
and that's why
we need
advocates
to really
are
look
incredible.
at that. I'm the strongest proponent you'll ever have for a vaccine, but it's got to be the right vaccine in the right place at the right time.
It's true.
Right.
Thank you for the great overview.
Thank you. Before we take the next question, I wonder if something that Patty mentioned made me go back to my questions that I had for you. So you want a vaccine that is off the shelf.
Yeah.
Now, one of the challenges, it seems to me, in breast cancer is that there's not a lot of overlap on the neoantigens that are expressed.
Well, so I'm not doing a neoantigen
Right.
vaccine.
So now we're talking about self-antigens. Overexpressed self antigens.
Yep.
So I guess there are a number of vaccine studies that are using neoantigens, and if we get, how might the platform influence whether or not we can utilize, create individualized vaccines that are comprised of their own neoantigens?
So I think the two issues is, first of all, do you have enough neoantigens to target? Because not everybody does. If you don't have a very mutated tumor, you may not find a lot of
This might be in secondary prevention.
And this would
Certainly
be and then my second
primary.
would be, unless you had conserved mutations in BRCA patients, which I think we're looking for, but we have not found to date. Because again, BRCA, similar to Lynch, your spell check for your DNA isn't right, and so you get a lot of mutations. But other than those two, we don't have conserved mutations. And if you were targeting mutations you found in DCIS, you can't guarantee that that will be in an invasive disease as well. So that's why. And trust me, I get plenty of, why aren't you doing neoantigen vaccines, as reviewers on my grants, and it's like, because I want to target the invasive disease. DCIS, as was said by the last speaker, or the last questioner really well, is not going to kill you, but what you want to do is prevent you from developing that invasive disease down the road.
Okay, so question from the audience?
Thanks. I'm Ann Fonfa. I run the Annie Appleseed Project. Our focus is on lifestyle. I always wonder how the combination of lifestyle in any clinical trial would be beneficial. So someone like myself, because of a comorbidity, I didn't do chemo. I now believe that I have stage 4 disease. I'm using Chinese herbal medicine as I did 18 years ago. My question is, have people been tested or people could be tested who don't fit the norm, who haven't had chemo, haven't had treatment? I have a whole world of those people who are closed out of clinical trials. Thank you.
It depends on the trial. Often with the trials, you have to have had the established therapies to be eligible for the trials. But it depends on the trial. Some trials are written, they tend to be the earlier stage trials that are, or you can't tolerate, and that opens things up a little bit more. But lifestyle, quality of life, it's becoming much more, and it really was advocates such as yourselves who got that into our trials, the quality of life questionnaires. I realize they're a pain in the neck, but they really do help, because when you see that everybody, yeah, they're doing great on drug X, but they feel like crap and they don't know how it's good to them, that's important. So quality of life is very important.
Okay, another question?
Hello, I am Marshall Harris, and I am with the Alamo Advocate Program this year, so I'm really happy to be here. And so I have a few questions. One of them is, how do patients get vaccines, and what is the process if you're not offered one?
Depending on the type of vaccine, it depends on how you get them. A lot of the DNA, RNA vaccines are in the arm. We typically go in the arm that didn't have the lymph nodes removed, or if both arms had lymph nodes removed, then the leg. Dendritic cell vaccines, as we mentioned before, they have to go into a lymph node and they're injected. The BRCA vaccine is actually electroporated, so you get a little electric shock along with the vaccine. It's not that bad. I've done electroporation vaccines, but it definitely scares people when you consent them. How to get vaccines. If you're not offered, clinicaltrials.gov is a bulky website, but can be an option. Depending on where you live, you can also check groups around you. I know the Cancer Vaccine Institute at the University of Washington has a wonderful website, and they talk about all of their trials. I know that the Earl Childs, we don't have any vaccine stuff going right now. I'm working on it. But we have a number you can call. So talk to your doctor and ask them about trial and trial options, because there's a lot out there, as you hear. A lot of them may require you to travel, though, depending on where you live. NBCC is a great resource, and the advocacy groups, really. Yeah. And then some of the ACS, the Breast of Us, a lot of the online groups. So.
And just to confirm, there's nothing to be offered yet other than access to a clinical trial.
Yeah.
Because there is no approved vaccine as of yet in breast cancer. So.
Okay.
Did that help at all?
Yes. So basically, the vaccines are like in clinical trials.
All
right
trials.
Now, so you'll be offered into that to get in that process.
Yes. Yeah.
And so my next question is, will this be a part of standard of care once it's approved and everybody will be offered?
Very much hoping. Yes.
Okay.
Yeah.
Thank you.
That's the hope. And some of the trials that you talked about, they're a little more specific to either BRCA mutated or triple negative. Those are two other prevention vaccines that are in clinical trials. We didn't talk about it here today, but we have talked about it on many occasions, so I imagine most of you have heard. NBCC is also in the process of developing a breast cancer prevention vaccine that aims to target all of the major subtypes and will be comprised of 6 non-mutated self-antigens that are overexpressed in most of the types of breast cancer. So we're still in the process of manufacturing that vaccine in collaboration with the National Cancer Institute's Prevent program right now, and Mayo. Please give me a note when it's time, because I don't have my phone up here, so I don't know how much time we have left.
I think
7
she's
minutes?
saying 8.
8 minutes, all right, good. We've still got some time, and there's a question out there.
Hi, everyone. I'm Lisa Chandler from Philadelphia. New patient advocate, grateful to Project Lead and to Sasha, who was there this summer, for translating the science. You know, it's very complicated. And I think one of my questions, I think you kind of answered, Michelle, was just what is the most promising platform for agnostic, for trying to develop vaccines for all subtypes of breast cancer?
Now,
Right.
quite honestly, if you ask anybody, they'll have different answers.
Right.
I said, I'm a CD4 girly. You got your CD8. We're scientists. We get our camps and we put our sticks in our hills, but this is all my opinion.
So are there any novel approaches that are being explored that, rather than targeting a specific antigen, and I also want you to speak to mRNA, given that, because they're so much less expensive to make mRNA vaccines, and you can make them so quickly. Believe me, I wish, to some degree that's the platform we had chosen, but that's not what for NBCC's vaccine. But are there novel approaches where you might be able to influence just the TH1, try to simulate or create a TH1 microenvironment? Are there any strategies that are being explored? Maybe not in breast cancer, but perhaps in other
So
cancers?
There's a lot of looking at, and this is getting really into the weeds. I did some COVID vaccine. When we were all trying to develop COVID vaccines, the Earl Childs tried to develop COVID vaccines, and they were finding that injecting even COVID vaccine, not a specific vaccine to a tumor, but into mice with tumors, was inducing enough of an immune response in that tumor that they were eliminating tumors. So doing getting non-specific immune responses. I don't know where this study is at UCSF, but Laura Esserman was looking at injecting PD-L1, immune checkpoint, into DCIS and trying to eliminate by infusion. Again, I always...
Intraductal, though.
Intraductal, yeah. So it wasn't systemic. I try to avoid systemic checkpoints in early patients. But that was a very valid point. But yeah, trying to introduce right into the tumor. The NCI Prevent, which is another great place if you're looking at prevention studies, they had a clinical trial where they were giving rexanoic acid receptor agonist to early breast cancer patients prior to surgery and trying to see how that changed the tumor. And that had been shown in preclinical studies to change the proliferation of the tumor, but actually also I had shown some work where it activated dendritic cells and dendritic cell immune recognition of the tumor. So there are a ton of different ways to do that.
I had one more
Yeah.
question, which is probably hard to answer. It's hard to even think about, but I understand learning about the heterogeneity of the tumor cells and how it's different in the primary tumor versus the metastatic tumor. Does that mean what does that mean for vaccine approaches? If you can speak to that.
So I think really where we are now with vaccine approaches is we want, and I know Artemis is doing this, we're doing this, we're really looking at multi-antigen because we want to catch that heterogeneity. So we want to target a lot of different targets rather than a single antigen. Because we see, like we saw with that Czerniecki vaccine, that you get antigen negative variants. So you basically select for the heterogeneous and you miss things.
Right.
So,
Which might not be a good thing. If
Which
it
might
grows-
not be a good thing.
It preserves maybe the worst part of
either the
tumor.
bad actors, we don't know.
Right.
That we don't know.
I mean, and I'll ask one last thing, and I think then we have to end. How about combining radiotherapy with vaccines? I mean,
Well, that's really interesting because radiotherapy actually is a vaccine
Right,
in itself.
right.
I was really disappointed. I had a trial going that was using vaccines in neoantigen vaccines in hormone receptor positive breast cancer. And we had to start by showing it was safe in women. And I have to say, I don't know that I would use this vaccine combination because it caused some ulceration problems that we got concerned about. But we were going to do that, and then we were going to use radiation plus the vaccine to try to see if the radiation would expand, because it was a single antigen vaccine, if it would expand the immune repertoire to that. So I think that radiation is very exciting. I'd really like to get a better vaccine platform. The company also went out of business. All of that did not help with this trial. But I would love to do that and combine it with radiation. Because we're doing some studies with breast cancer with inter-op radiation and not needing to give such high doses. So.
All right, well, I don't see any other questions, and I think we're about out of time. So thank you, everyone, for attending and listening to Sasha, who is just excellent. We're very fortunate to have her at Project Lead, and for those of you who haven't attended, please check out our website and look into it.
Yeah, please come to Project Lead.
You learn a
It's
lot
really
more about
fun.
this stuff.
It's really, really fun. I love teaching you guys. You ask the hardest questions.
All right, thank you, everybody.